Imagine a majestic horse, just standing calmly in its stall. Everything seems fine on the surface, right? But deep inside, maybe there's this silent danger lurking internal bleeding, perhaps even life-threatening, with no obvious external wounds. It's a terrifying thought, isn't it? That vulnerability. How something as fundamental as blood clotting can suddenly go completely awry. So today, we're embarking on a deep dive into exactly that, acquired coagulation defects in horses.
Hmm.
Our mission here, and honestly it feels like a real medical detective story waiting to unfold, is to try and unravel the complexities. How these magnificent animals can suddenly lose their ability to clot blood effectively, or, sometimes clot too much, which is also a problem. We're aiming to give you a shortcut, really, to understanding these critical, often life-threatening conditions. So, okay, let's unpack this. How does a horse's, finely tuned system for stopping bleeding suddenly just break down? What are we looking for?
Well, what's fascinating here, you touched on it, is how often these acquired issues are really a ripple effect from something else entirely, often something much more serious going on underneath. These aren't just rare veterinary curiosities. They are frequently complications of severe underlying diseases. That makes diagnosis and treatment a huge challenge. And understanding this isn't just for vets, I think. It's for anyone who cares deeply about animal health, or frankly, anyone who enjoys a deep dive into how biological systems can sort of unexpectedly go wrong.
Okay, so our first clue then in this medical mystery,
Yeah.
we need to understand, what exactly does it mean for a horse to have an acquired coagulation defect? We hear terms like hemostatic dysfunction, bleeding tendencies.
Right. Essentially, an acquired coagulation defect means the horse's amazing ability to stop bleeding is compromised somehow. And crucially, like you said, it's acquired, meaning it's not something they were born with. It's something that develops later in life. These defects, they typically show up in one of three main ways. First, you can have disorders that specifically impair the formation of a good, stable blood clot. These are what we call true coagulation defects. Second, there are issues that impair that initial patch, the one formed by platelets. Either the platelets themselves aren't working right, or maybe the blood vessels are damaged. And third, and this one's often the most dramatic, are disorders where the body starts clotting so uncontrollably that it literally uses up all its clotting resources. That's called a consumptive coagulopathy. And disseminated intravascular coagulation, or DIC, is the prime example there. It's kind of like a factory going into absolute overdrive, producing so much product that exhausts all its raw materials, leading to a complete shortage just when you need them.
Wow, okay, that really helps define the battlefield, so to speak. So with these different types of defects in mind, let's zoom in on what you called the engine room of clotting, the vital roles of vitamin K and the liver. So what does this all mean for how a horse actually clots blood, and what happens when these essential components are missing or, compromised?
Yeah, vitamin K is absolutely crucial. It's like the key ingredient the liver needs to produce several essential clotting factors. Factors 2, 7, IX, and X, and also protein C, which is an anticoagulant. So if a horse has a vitamin K deficiency, these factors gradually decrease in the bloodstream. This leads to this progressive impairment of their clotting ability, and ultimately you can get unexpected bleeding. What's particularly interesting, I think, is how quickly this can manifest. Factor 7, it has the shortest half-life, less than 6 or 7 hours. This incredibly short half-life is actually our earliest alarm bell. It means the PT test, the prothrombin time, which checks this factor, can give us a critical heads up about vitamin K deficiency, often hours before any other signs of bleeding might appear. It's a really powerful early diagnostic clue. Then, as the deficiency progresses, other factors decrease, affecting other parts of the clotting process, which we check with a different test called the aPTT.
Okay, so factor 7 goes first. PT flags it early. What causes that vitamin K deficiency in the first place?
Well, common causes include things like ingesting moldy sweet clover hay, or maybe other plants that have coumarin glycosides, some ferns, certain pines, Ferula communis. We also see accidental ingestion of rodenticides like warfarin or brodifacoum. And you really have to be careful with those. They are very potent and can cause prolonged bleeding, sometimes for weeks. Less commonly, maybe chronic intestinal malabsorption could decrease vitamin K absorption. And while it's not as frequent in horses compared to other species, prolonged antibiotic use can sometimes alter the gut flora enough to affect vitamin K production.
And the liver. You said it was like the master factory.
Exactly. Think of the liver as producing almost all the clotting components. So when that factory goes down due to severe liver disease, it's not just one or two parts missing, it's more like a systemic shutdown of the entire clotting assembly line. It impairs the synthesis of most coagulation factors. Factors 1, 2, V, 7, 9, X, 6, 7, 12, and 13, plus the natural anticoagulants like antithrombin, protein C, and protein S. This leads to a profound, generalized bleeding crisis. And on top of that, liver disease can also mess with how well the platelets function.
Goodness. Okay, and you mentioned something about the immune system attacking factors. That sounds rare.
Very rare, yes.
Yeah.
But it happens. There was a recent report of a mare developing an acquired coagulation factor 8 deficiency, essentially, acquired hemophilia A. Her own body produced antibodies against her factor 8. This is an example of how the body's own defenses can, unfortunately, turn against itself sometimes.
That's quite a list of vulnerabilities just in the clotting system itself. Now, the sources describe disseminated intravascular coagulation, DIC, as the most common and complex acquired hemostatic disorder in horses. And you mentioned it earlier. I've heard it described as this condition where a horse can be clotting too much and bleeding too much simultaneously. That sounds like a complete paradox. How on earth does that work?
You've hit on the core of its complexity, exactly. DIC isn't really a primary disease in itself. It's more a severe secondary syndrome that develops in response to a whole variety of underlying conditions. What happens is there's this systemic kind of runaway activation of coagulation all throughout the body. This leads to the widespread formation of tiny blood clots, or microthrombi. These microthrombi, they're like miniature traffic jams forming everywhere in the horse's tiniest blood vessels. They block blood flow, preventing oxygen and nutrients from reaching vital organs, which, as you can imagine, causes significant damage. Now, this intense clotting process consumes platelets and coagulation factors at such a rapid rate that the body's reserves just get completely depleted. So while clotting is happening excessively in some areas, the horse ends up with this paradoxical bleeding tendency in others because it literally runs out of the necessary clotting materials. It's a real mess.
A vicious cycle, really. So what kicks off this catastrophic cascade? What are the common underlying causes?
By far the most common underlying cause for DIC is sepsis or endotoxemia. This results from severe infections like bad colitis, pneumonia, or peritonitis. The bacterial toxins trigger this massive inflammatory response that just activates the coagulation cascade uncontrollably. Other common causes include severe acute colics, especially those nasty strangulating lesions of the intestine, also severe trauma or major surgery, certain types of cancer, some immune-mediated diseases, heat stroke, severe burns, and even anaphylaxis can trigger it.
Wow, okay, that really is a vicious cycle. The body is essentially fighting itself and losing on both fronts. So if a horse's body is creating these microclots and running out of clotting factors, what else can cause these serious bleeding problems beyond just the coagulation factors themselves? Let's shift focus maybe to platelets, those other critical components you mentioned.
Absolutely. Platelets are vital for what we call primary hemostasis. They form that initial plug right at the site of injury, like tiny first responder bandages. So a significantly low platelet count, or thrombocytopenia, will definitely impair this process and lead to bleeding. Causes of low platelets. Well, there's immune-mediated thrombocytopenia, or IMTP, where the horse's own immune system attacks and destroys its platelets. They can also be consumed, like we just discussed with the IC. Or they can get sequestered, kind of trapped, in an enlarged spleen. Or sometimes there's decreased production because the bone marrow is suppressed, maybe from a severe infection or certain drugs. And of course, in cases of massive hemorrhage, platelets can also get diluted if the horse receives aggressive fluid resuscitation without platelet replacement.
Okay, so number matters. But what if the numbers are fine, but the platelets just aren't working?
Exactly. That's thrombopathia. Platelets are present, but they simply don't function right. A very common cause of this, something many horse owners might encounter, is giving NSAIDs, like aspirin, or more commonly in horses, phenylbutazone, bute. These drugs inhibit platelet function. Some antibiotics, particularly at very high doses, can also interfere sometimes. And uremia, which is severe kidney disease, is another known cause of platelet dysfunction.
Right, I've heard about bute affecting clotting. What about the blood vessels themselves?
Good point. Then we have vasculitis, which is inflammation of the blood vessel walls. This can lead to the vessels becoming fragile and leaky, causing bleeding even if platelet counts and coagulation factors are perfectly normal. It's commonly associated with Streptococcus equi infection that causes purpura hemorrhagica. But other infections and even drug reactions can be culprits too.
And you mentioned anticoagulant toxicosis earlier, like rodenticides.
Yes, exactly. We can't forget that. Well, warfarin isn't really recommended anymore in horses, and heparin use is mostly restricted to critical care patients. Accidental ingestion of anticoagulants is still a concern, or even therapeutic administration that maybe goes awry. For instance, the risk of warfarin toxicosis can actually be increased if it's given alongside other drugs that bind albumin, like phenylbutazone. or in horses that already have low albumin levels.
Okay, it's clear the whole system has many potential weak points. But for someone looking at their horse or a vet in the field, knowing what to look for is absolutely paramount. So when these issues actually manifest, what are the telltale physical signs? Do different defects present with different sort of clues?
They absolutely can, yes. And trying to differentiate them based on signs is a key part of the initial assessment. Generally, you might see spontaneous bleeding, maybe from the nose, mouth, rectum, or bleeding into body cavities. You might see hematoma formation, which are those large blood clots under the skin or deep in muscle. And prolonged bleeding after even minor trauma or a routine surgery is definitely a red flag.
Okay, so that's general bleeding. Are there more specific signs?
Yes. Now, if it's a primary hemostatic defect, meaning an issue with the platelets or the blood vessels themselves, you'll often see those pinpoint hemorrhages we call petechiae. You'll see them on mucous membranes like the gums or inside the eyelids or sometimes on non-pigmented skin. You might also see larger bruise-like hemorrhages called ecchymoses, nosebleeds, epistaxis, blood in the urine, hematuria, or signs of GI bleeding like dark, tarry stools, melena, or even fresh red blood in the feces, hematochezia. And here's a really important diagnostic clue. Petechial hemorrhages are usually absent in acquired coagulation factor defects. That helps distinguish them from primary hemostatic deficiencies, or DIC.
Ah, okay. So if you see those little red dots, think platelets or vessels first. What about the factor problems?
Right. For secondary hemostatic defects, which involve the coagulation factors, the bleeding tends to be deeper and often more severe. This can include those large, deep subcutaneous or intramuscular hematomas, bleeding into joints, causing painful swelling, which is called hemarthrosis, or bleeding into body cavities like the abdomen, hemoabdomen, or the chest, hemothorax. You might also see severe and sometimes delayed bleeding after surgery, or tragically even sudden death from a massive internal hemorrhage that wasn't obvious externally.
And the flip side, the excessive clotting.
Good question. If the horse is experiencing hypercoagulability or excessive clotting, the signs are different again. You might see things like thrombophlebitis clotting and inflammation in veins, like the jugular vein, especially if it's had a catheter. Laminitis can sometimes be associated with microthrombi forming in the tiny blood vessels of the hooves, and colic can occur if clots form in the blood vessels supplying the intestines, mesenteric thrombosis. These microthrombi can also just generally cause organ dysfunction because they block blood flow.
And you always have to look for the underlying cause too, right?
Always. Remember to look for signs of the underlying disease. Is there a fever and lethargy suggesting sepsis? Is the horse jaundiced, pointing towards liver disease? Is there muscle weakness or incoordination, maybe suggesting rodenticide toxicosis? Those clues are critical.
It's incredible how specific those physical signs can be, really offering us vital clues. So, okay, you see these signs. What's the next step? Like any good detective, once you have clues, you need to gather evidence. How do veterinarians actually piece together this puzzle to figure out which specific defect it is and maybe even more importantly, why it's happening?
It definitely is a journey, yeah. And a systematic approach is absolutely essential. The first step is always a thorough clinical assessment, looking at those signs we just discussed, and then getting a blood smear to examine. We need to check the platelet count and their morphology, how they look. A manual platelet count is often preferred in horses because automated counters sometimes get confused by platelets clumping together, which they tend to do.
Okay, check the platelets manually. Then what? Screening tests.
Exactly. Then we move to key screening tests. The prothrombin time, or PT, is like a quick timer for one of the main clotting sequences specifically, the extrinsic pathway, the one that kicks off clotting when there's external damage or tissue factor exposure. If this timer takes too long, like we said, it's often the first sign the vitamin K might be low because factor 7 drops first. The activated partial thromboplastin time, or aPTT, is a timer for a different, more internal pathway of clotting, the intrinsic pathway. We also measure fibrinogen, which is a crucial clotting protein itself. And finally, there's the activated clotting time, or ACT. That's a simpler, less sensitive test you can sometimes do right at the bedside. It's kind of like checking two different roads, PT and aPTT, to see where the traffic jam is starting.
Gotcha. And what if those initial tests point to something serious, like DIC? Are there more specialized tests?
Yes, absolutely. For more specialized differentiation, measuring D-dimers and fibrin degradation products, or FDPs, is critical. These are essentially the waste products created when the body breaks down clots. If these are highly elevated, particularly if D-dimers are over, say, 2,000 ngml, it strongly points towards DIC, whereas in vitamin K deficiency, they're usually normal or only mildly increased, maybe less than 1,000 ngml. So that's a key differentiator. Measuring antithrombin activity is also useful. Decreased levels indicate ongoing clotting, which is common in DIC. The buccal mucosal bleeding time, or BMBT, is an actual in vivo test. You make a tiny cut on the inside of the lip and time how long it takes to stop bleeding. It tests primary hemostasis, platelet function right there on the horse. And increasingly, especially in critical care settings, vets are using thromboelastography, or TEG, and rotational thromboelastometry, ROTEM. These advanced tests are amazing. They're like creating a real-time movie of the blood's entire clotting process in a lab machine. Instead of just a snapshot like PT or aPTT, they show us how quickly a clot forms, how strong it gets, how stable it is, and even how quickly it breaks down. It gives us a really complete global picture of the horse's clotting ability from start to finish.
Wow, TEG and ROTEM sound really comprehensive.
They are. But maybe the most important part of the whole diagnostic journey, honestly, is identifying the underlying cause. Whether it's doing blood cultures to look for sepsis, maybe liver biopsies if liver disease is suspected, or toxicology tests for rodenticides. Finding and addressing the primary disease is absolutely paramount for effective treatment. You can't just treat the symptom, you have to treat the cause.
That really paints a clear picture of the diagnostic steps. Okay, given how incredibly serious these conditions sound, once a defect is identified, what's the plan? This sounds like an emergency. What's the response to actually help these horses?
You're absolutely right. These cases are very often life-threatening emergencies. They need immediate attention. These patients are almost always managed as inpatients, usually in a hospital setting, because they need really close monitoring.
Yeah.
We need to track their clotting times frequently and watch constantly for any signs of ongoing or new bleeding complications. If there's profuse bleeding happening, it's truly an immediate, life-saving emergency situation.
So what are the first lines of defense? Transfusions.
Often, yes. Transfusions are frequently necessary. Fresh whole blood is great because it provides everything: red blood cells for oxygen carrying capacity, platelets for plugging, and all the coagulation factors. It's typically used for severe active hemorrhage. Fresh frozen plasma, or FFP, provides the coagulation factors and the natural anticoagulants, but without the red blood cells or functional platelets. So FP is often ideal for treating specific factor deficiencies like those you see in liver disease, or to help manage the consumption of factors in DIC.
And what about vitamin K deficiency? You mentioned a specific treatment.
Yes, if it's confirmed or strongly suspected to be a vitamin K deficiency, then vitamin K1, the specific form is phytonadione, is the drug of choice. It's usually given subcutaneously, under the skin, or sometimes orally, until the PT values return to normal. And remember, for those really potent, long-acting rodenticide toxins like brodifacoum, treatment might need to continue for weeks, even months sometimes, because the toxin has such a long half-life in the body. We might also cautiously use antifibrinolytic drugs like aminocaproic acid. These help stabilize clots and reduce bleeding, but you have to use them carefully because there's a delicate balance. You don't want to tip things too far the other way and promote excessive thrombosis or clotting. Makes sense. What about general care? Good nursing care is also absolutely vital. Minimizing any trauma is key, so careful handling, minimizing venipunctures as much as possible. Exercise should definitely be restricted while clotting times are prolonged. And interestingly, providing good quality green leafy feeds like alfalfa hay is often recommended because it's naturally high in vitamin K1, which can help support the horse's own production if absorption isn't the issue.
Right, support the system. And tackling the underlying cause is still key.
Absolutely, the most important part. Treatment must address the underlying cause. That means aggressive fluid therapy and antibiotics if it's sepsis. Supportive care, often focused on nutrition and managing complications if it's liver disease. Or maybe immunosuppressive therapy like corticosteroids if it's immune-mediated thrombocytopenia. That's the core of successful treatment. And if the problem is actually hypercoagulability, excessive clotting, then we might use anticoagulants like heparin. There are different types: unfractionated heparin and low molecular weight heparins like dalteparin or enoxaparin. These can be used carefully to try and prevent further thrombosis in high-risk horses, for example, those with severe colitis who are prone to clotting complications.
Okay, so a lot to manage. Are there things that should definitely be avoided?
Yes, definitely. Critically, you need to avoid administering other anticoagulants or antiplatelet drugs like NSAIDs, as these will only worsen the bleeding tendency. Also, parenteral vitamin K3 is known to be nephrotoxic, damaging to the kidneys in horses, and should never be used. Always use vitamin K1. And be mindful of certain drugs like phenylbutazone, heparin itself, and salicylates like aspirin, as they can potentially interfere with vitamin K1 binding or action and should generally be avoided if possible in these situations.
Got it. It sounds like a really precise and urgent dance between supporting the horse directly and tackling the root of the problem itself. So, once diagnosed and treated, what's the typical outcome for a horse facing one of these complex issues? What does the future generally hold for them?
Yeah, the prognosis unfortunately really varies widely. It depends heavily on the specific underlying cause, how severe it is, and how quickly and aggressively the condition is diagnosed and managed. For vitamin K deficiencies, particularly those caught early and treated appropriately with vitamin K1, the prognosis is generally quite good. You often see a rapid resolution once treatment starts.
That's encouraging. What about the more severe conditions?
Well, for the more severe conditions like DIC, severe advanced liver disease, or cases of severe rodenticide toxicosis, the prognosis is often much more guarded, even poor. These conditions frequently carry high mortality rates, unfortunately, despite intensive care. For things like immune-mediated thrombocytopenia (IMTP), it can be variable. They can respond well to immunosuppressive therapy, but relapses are certainly possible down the road. The key takeaway here, really, and something that can genuinely make all the difference in outcome, is that early diagnosis, aggressive supportive care, and decisive treatment of that primary underlying disease are absolutely critical to improving the chances for these horses. Timing and addressing the root cause are everything.
So, what does this all mean for you, listening? We've taken quite a deep dive into something as fundamental as blood clotting and seen how incredibly complex and sometimes fragile it can be when things go wrong in horses. From vitamin K issues to liver disease to that baffling paradox of DIC and the critical role of platelets, understanding these deep connections, these potential ripple effects can truly make all the difference. Whether you're a horse owner trying to spot early signs, a vet student learning the pathways, or maybe just someone who loves a good scientific puzzle.
And maybe this raises a slightly broader question, too. In a world where we have so much information coming at us, how do we train ourselves to spot these kinds of ripple effects more effectively? Where a problem in one system suddenly cascades into seemingly unrelated complications somewhere else. What other seemingly isolated symptoms, maybe in health or even just in our daily lives, might actually be indicators of a deeper, more systemic issue that we're perhaps overlooking? It's something to think about.
Definitely something to think about. Keep that curiosity alive, and maybe, just maybe, you'll be the one to spot the next critical ripple effect in whatever deep dive you decide to take next.